see, a question I have for you is for the VUS patients that you said, and you said that you put those in the low-risk category. However, what we are learning in the US is that with newborn screening, there are many, many new VUSs that are being identified, but there is a need for reclassification because some of them could be pathogenic or likely pathogenic. How are you approaching this in Taiwan?
Thank you, Priya. When we classified them as low risk, I mean with the genotype, with the biochemical phenotype, if they those parameters shows low risk, I will put them as a low risk. However, if they have, for example, elevation of CK or urine group 4, although they have VUS, I will put them temporarily to the medium or high risk to until we have further evidence.
Are there any questions from our esteemed audience? To take the mic. And if you could give us your name as you speak. Yes.
Dominic D'Agostino, University of South Florida, Morsani College of Medicine. We're doing some preclinical animal model work. And I wondered if someone has thought of the idea of delivering ERT with an acid, ascorbic acid, like you can give intravenous 25, 50 milligrams and quickly acidify the blood in the tissues with something like ascorbic acid, which is used routinely in different clinics. Has anyone tested that idea? No? Okay.
Not to our knowledge. If you've done it in your animal model, please do share with us.
Yeah, it's used. I do cancer research too, and intravenous ascorbic acid, people have mixed opinions about it, but we do know it's safe, and we do know it permeates the tissues, and you can deliver in gram quantities, and it's an acid that's kind of strong. So I was thinking maybe it could augment ERT in that way, and it has some beneficial effects in and of itself too.
It's definitely something that should be that could be explored, but I would also address that the pH in the blood is about 7.4, 7.5, 7.45, and the pH in the lysosome is 4.3. So there's a large difference, and I think we don't want to have a pH of 4.3 in the blood because that we will not survive. So it's definitely something to explore, but now we have to see the effect.
I agree, and I also wanted to add a comment that the half-life in blood is really short. The uptake is pretty quick. And so I think the key is to get it into the right compartment, and I think that's what this focus has been on. Any other questions? Yes.
Can I add to this?
Yes.
Because the acidic form, acid alpha-glucosidase, is stable up to pH 7.
Yes.
It's really no problem. If you go above pH 7, it may slowly deteriorate. And no one has ever measured the stability of acid alpha-glucosidase in blood, in the tube. People measure in the body, and in the body it goes to the liver. So it doesn't tell anything about the stability of alpha-glucosidase in the blood. So I don't really think it needs to be acidified unless proven.
Pascal, I think.
Good morning, Pascal Laforêt from Paris. I am a neurologist. I would like to congratulate my colleague for the nice presentation. I just want to ask a question to everybody regarding the neonatal screening from the point of view of the adults. Just to have your idea, I am a little afraid that I think this is a great progress to start, and this is a revolution of the NBS, and we see the same in SMA. We are able to treat now very early the more severe form of the disease. But regarding the adult form, I'm a little afraid that you will have a lot of LOPD diagnosed in the next years, And what will come with this patient, when you have a young patient with a mild motor delay, it's not so rare, not obviously related to Pompe disease, when should we start the ERT? And I am a little afraid that many children will be treated, over-treated, perhaps very early, knowing that the disease may reveal very, very late. We all know that. How do you cope with this challenge in the future?
Thank you. So this question has been answered from our previous nature history of LOPD in Taiwan, because in Taiwan, actually, we have a majority childhood onset Pompe disease. So they end to respiratory value around the age of 20s. So we think that if we can move the treatment probably to age 7 or even age 3, that is quite reasonable to that population. I understand that probably in other population they have a more common adult onset, so I think I will leave that question to you.
I would like to comment on this because we've now had newborn screening in the US, and there is a lot of new learning with 44 states on board, and the most common variant is the leaky IVS splice site variant, usually in compound heterozygosity. And we've had the privilege of actually seeing a large cohort of these at Duke in collaboration with many of our US colleagues. What we have seen is that many of these babies, do have an elevation of CK. They have an elevation of the AST, so the biomarkers are already increased. It's not just at the time or around the time of birth, labor, and delivery. We are seeing this has consistently been elevated or continue to increase. That's one aspect of biochemical evidence of the disease. The most important is the multidiscipline team approach, and we have been working very closely with PT and Laura cases here. It is that pattern of muscle involvement that we are seeing is what we are seeing is similar to what we would have seen in adults with LOPD, with the pelvic girdles, the hip extension, abduction, etc. And then to further build on that, we've now started also doing further biomarker evaluation with muscle ultrasound, which you'll hear Neha speak about in the afternoon, with evidence of increase in echo intensity in these patients, and some of them, not all of them. And then, to top it all, some of them who've had opportunistic muscle biopsies, so if they've undergone anesthesia for other reasons, if you start seeing those muscle biopsies, it is quite concerning to already see a lot of extra lysosomal glycogen accumulation. So I think there's a lot of compensation, as we all know, that occurs, and there's a different rate of disease progression, but there is a subset of babies with the broad terminology of LOPD, which goes anywhere from before the first year of life to the 6th decade, that do present early and I think have clearly benefited from early diagnosis and management.
Very short question on that. You say that you see the pattern of muscle weakness around the pelvis. What do you see in these patients? Because I think that the clinical symptoms, of course, the biochemistry, it's all important, but in the end, it's the clinical picture of the patient.
Absolutely. So many of them have kinematic and postural abnormalities, like aspects of hips in abduction and constant external rotation. They have evidence, of showing us on a GMFM that they've got neck flexor weakness that's already present that's in these babies. They have difficulties when you put them in the prone position, you compare them to typically developing peers, there is evidence already of involvement. So I think it has been an eye-opener even for us as we have watched many of these babies, and I think they could have gone through several years without being diagnosed but have been called lazy children or developmental delay and have been identified. And now if you go back to the clinical literature, many of us have published, including the Dutch group, us, on the very IVS splice site, and patients who have clinically presented in the first few years of life. So I think that this is new learning, and I think time is going to teach us and tell us a new natural history, I think, of LOPD as well, including the nomenclature.
Hi, I'm Mark Tarnopolsky from McMaster University Children's Hospital. One of the challenges we have in our patients, as you've pointed out, Mark, is that about 50% of them after 5 years get almost a tachyphylaxis to current ERT. So you see this initial improvement in vital capacity and 6-minute walk, but between 2 and 5 years, about half of our patients are starting to decline. So for me, the real clinical issue now is how do I switch and what drug do I switch to? So we're a bit of a slave in Canada, as I'm sure we are in all regulatory jurisdictions, to approve drugs based on what the design of the study is. And the challenge I have with the COMET study is that these were naive patients, and the switch data are on people who are on Myozyme for just 1 year. And that's not really what we see in the clinic. My big issue is my 20 patients who've been on Myozyme for 5 years who are no longer getting benefit. And that's a different scenario if I were to switch them to AVA, because they're sort of in that decline period versus the structure of the study was only 1 year when they're still in the sort of upslope and beneficial phase of the design. And so we're having a real problem in Canada where they're saying, well, look, we're only approving it for naive patients, and I can't switch my declining patients now. And until Amicus, comes to the Canadian CADITH, and maybe we get the Amicus SIPA product approved, we really have no options for switch in Canada at this point. I just wonder how you deal with that.
Wow. I think what you speak to is that whilst trials are important for licensing purposes, it's real-world evidence that really informs our clinical management. You could argue the same with regard to SIPA. There's very little naive data from the trial. So should that stop us using SIPA in naive patients? But how will we ever know if they help naive patients unless we try? And there are going to be major differences across the world with certain products licensed in certain jurisdictions and not others. I think you're absolutely right. So I really think it's the real world data, and this will lead into talks that Benedict and others are going to give about the importance of engaging with patients to get them into registers and to monitor them, to give us that evidence, and not least for funders of healthcare to be convinced of the arguments for these new treatments. Because what's the alternative? That we just watch our patients declining on Myozyme after initial improvement. And that would be a grim thought indeed, where these new enzymes are clearly an evolution. I'm not saying a revolution, but they're an evolution in care.
We have a question over here.
Ryan Colburn, Odin Incorporated. So following up on Pascal's question, setting aside payer considerations and impact on scheduling and life and all those kinds of things, is there actually any concern for harm brought to a patient starting ERT in a more timely manner? And just to preface one potential direction of answer I'm anticipating, the efficacy waning over time that may come. I think there's an inverse evidence of an inverse correlation with starting earlier having longer durability, but I want to just really separate the discussion, make sure that we're not talking about a medical health concern about starting early, are we?
It is a difficult discussion, of course, because is it medical harmful? No, but it costs 4.5 hours every week, every 2 weeks. So, and the traveling back and forth or home therapy, it's time that patients can use for other things, which are also very important in life. So that's why we look for a perfect case definition of when to start treatment, because of course we want to start early, but you want to start on the right point without losing time when it doesn't bring you enough positive things, when it doesn't gain you enough. So in a way, is that harmful? No, not medically. Does it harm your life? Yes, I think. Yes.
And I think that's a point really well taken, and it's really a conversation with the families. It's not an emergency. It's a discussion. It's a conversation. And when we mean management, very often it's just physical therapy, right? Intervention, like doing something positive, to help these children continue to maintain skills. And then when it appears that the disease is progressing, that's when, a discussion around enzyme therapy has occurred. And I think there has been a misnomer or a misunderstanding that you would plateau after 2 years on treatment. I think it's the stage of the disease when you are initiated on therapy, when you are reaching your salvageable muscle fibers, and also dependent on the enzyme therapy that you're on. I think with next generation therapies, the hope is to better target, and so to get further benefit. And so I think that also has to be clarified, that it doesn't mean that if you start today, that 2 years from now you're going to plateau or stabilize. Thank you.
We have a question over here.
Hi, so I'm curious, in the first presentation you mentioned a couple of the patients had epilepsy. What concerns, if any, are there to epilepsy or seizures and Pompe disease? Or is any other country seeing that?
Yeah. First, what other countries have seen this? Well, we have seen this. I know Priya has recently published on that. And I know that in the German cohort, there are also cases. There are cases in the UK cohort, and there are also cases in the Taiwanese cohort. So it seems to be part of the new phenotype. However, it is rare. That's why it took us so long to find it. You need bigger cohorts to find this, and right now we're only getting to know the new phenotype. So now we see that the epilepsy does occur. We know that in other diseases in which white matter is involved, that epilepsy can occur as well. And what is the exact cause behind the epilepsy, that we still have to learn to know.
So I have more comment than Benedict Joseph from Munich. So talking about newborn screening, early treatment is something we need to give back to the patients. So my clear impression is we have to ask them, especially the late onsets, what they would consider for their life if they have started at the age of 2 already being a patient, being every other week or even every week on treatment. Because that's the decision maker here. It's not our wish that we preventive treat, because we don't know if this is preventive. So if the drug is really that good, even the new enzymes, we don't know that. So prevention would be the higher ground, but this is completely unclear if we can really prevent disease manifestation. And then the burden of treatment impacts your life definitely. You don't have a normal development as a kid any longer if you start that treatment. So therefore we need to ask really all the patients what they would consider for their life, and should be a type of APR questionnaire or survey, whatever type of things to look into this. It would be perhaps also a very appropriate approach to handle this type of situation.
I agree with you. And in fact, there are surveys for parents of children identified via newborn screening. And we should ask both. But there are studies going on in the US, and Erin, who's my genetic counselor, and other groups have been working on this as well.
Hi, I'm Jordi Diaz from Newcastle. So as a follow-up comment to what Benedict just said, I think it is very important to define what we consider clinical involvement in patients, especially these patients that you were mentioning. That's it's too vague sometimes to define what does it mean. So we all have seen patients that are pre-symptomatic, that have a bit of neck weakness in the clinical examination. But in my case, I've seen these patients doing perfectly well by playing football, riding a bike, or dancing. So it's very difficult, I think, to say what is the cutoff. And just to go into the next session, I think that we need to start looking for all the biomarkers that can contribute. In my case, of course, I'm going to defend MRI, but I think it is important that we have a look to the whole picture and not only. My impression is that this patient has a bit of muscle weakness, and therefore we should start treatment now, because sometimes I insist this definition is too vague.
Yeah, and I would also like to add to this. I think to two things. First, asking the patient, and I think it's very good to do it in a broader way, in an IPA way. We also did it in the past, and there, together with a large research on the normal population and on patients with Pompe's disease, also the adults with Pompe's disease and their families. And then there came out that they were in favor of doing neonatal screening. But I also would like to focus indeed on the fact that both, I know, Pascal, you have published, and also we have found patients who are accidentally found because they have a high CK, and we follow them for 20 years without symptoms. So I think we should be very cautious, and always, that's the downside of things. So we should be cautious and not start too early, and there is time. Also, maybe also good to mention is that there are certain fusses that now influence, for example, splicing, the C510C to T. For example, if a patient with an IVS1 has this variant in addition to the IVS1, we now know that these patients present earlier with symptoms. And also, something that we should maybe consider is if you have a double IVS1, the majority will never have symptoms, so they do not have Pompe's disease.
Correct, and totally agree with all these comments, and that's why taking the full approach when we are approaching and managing patients, and I think this is a message for our families. And I think Laura would also like to make a comment. Not every baby gets treated. We are looking for the 510C to T. We are taking a complete holistic approach and a full evaluation before a decision to treat. And I think that's also what's going on at other centers in the US, because yes, there is a risk benefit, and we've got to be respectful of this being a lifelong until there's a next therapy that arrives. But this reminds me of the conversation of many, many years ago when we sat on this podium, right dose, when to start, immune modulation, CRIM, etc. So I think we've entered a whole new era of discussion, and so this is what keeps us all thinking and awake at night for the field. Thank you.
Okay, hello. Hold on just a second before your next question. She has a response to this topic. I'm going to come right back to you.
Laura Case, PT at Duke. And so I just want to support to have the parents that have started, I think it's very important to hear from the families. And so for the parents that have started early, very early, I think it's really important to hear from them on the impact that they feel that it's had on their life and their child's life. I think that's really important. And for the information I'd like to get out to the physical therapists doing evaluations, as Priya said, it's the pattern that we see. So if you see sort of overall developmental delay or a little bit of low tone in somebody, that's one thing. But if you see that there is imbalance, weakness that you can see in the same pattern that you see in the adults later, then I think we are spotting something early that has something to do with Pompe and something to do with the muscles. So I think it's really important for us to scrutinize that and to see what that means over time.
Brad Crittenden from Canada. This is actually an online question that we have. Question to Professor Roberts. How do you see a combination of AVA with an enzyme stabilizer, such as miglustat? Has this, or is this being tested? Or are current tests with SEPA only being done?
Well, there certainly hasn't been any trial of AVAL with a stabilizer. But as I understand it, and there's people from Sanofi here, they have tried that approach and have not seen the enhanced benefit that was seen with the SIPA miglustat combination. So I think they have tried, but it hasn't been tried in a formal clinical trial. And as we all know with the heterogeneity of Pompe, that will be the acid test. No pun on acid alpha-glucosidase there. So I think that's the answer. It's something that could certainly be tried, but it hasn't been done in a formal clinical trial setting that would enable us to have confidence that that combination too might be useful.
Good morning, I'm Wilma Treur from the Netherlands. And I was just wondering, I think we can say that most children are now on a double dose and are doing better. That's something we are a little bit jealous on as adults. But besides that, I was just wondering what is happening when they become an adult? That's the first question. And if you have already children who became adult for a few years and getting still the double dose, how are they doing?
Okay. That's a very good question, I think. And let's first get to what do we do if they reach adulthood? They remain on 40 mg per kg per week. Of course, their residual activity is lower than the late onset patients have, so it's kind of a good sense to just remain on the same dose. How are they doing? Well, it's a very severe disease, and there is still residual muscle weakness and unmet medical needs, and they get worse when the children grow older, and that's the classic infantile Pompe patient. So the patient with a hypertrophic heart, it's within the first year of life. By the time they become adults, they mostly have muscle weakness, and they are either wheelchair bound or at risk of losing the ability to walk. But I think your question touches upon something else, and I was just wondering if you're inquiring on the fact if a higher dose could also help in adult patients. And what I've noticed in the audience with the patients is that the doses of the patients, of the late onset patients, vary remarkably. Some patients are on 20 mg per kg per 2 weeks because in some countries you cannot give 40 mg per kg weekly. And in other patients, they live in countries where it is possible to get 40 mg per kg per week. So I think already within the audience there are quite large dose differences. So, yeah, well, there are second generation therapies coming up, but those remains an issue, I think, and we still should look within the whole worldwide cohort if there's a difference in the different dose levels.
And very much to echo those comments about the variability in the infantile dosing. So Alex Broomfield at Great Ormond Street continues to fight for 40 milligrams per kilogram weekly for the infantile patients, so it's not easy. We have got 2 IOPD patients that have actually moved to the UK who were on 40 milligrams per kilogram weekly, and NHS England has agreed it would be unethical to lower their dose. But that's unusual, and we're still fighting in the UK for 40 milligrams per kilogram weekly for the infants.
We can take one more question and then it's time for a break.
2 more.
Two more? Okay.
My name is Gina Concannon. I'm a parent, so really out of my element. I'm curious. My son was just diagnosed this January. He's completely asymptomatic, but he has started enzyme replacement therapy. He's doing 20 milligrams every 2 weeks. And he's a teenager, so he's doing this fabulously because he's gaming while he's taking his treatment. What I'm curious about, I work for a research institute that focuses on geospatial science research and have felt compelled over the last few months to find a way to help this community. And I'm wondering, with all of these esteemed researchers in the room, is there an aspect of this research that includes geospatial science? And if there's not, would it be useful since all people all around the world are affected by this disease?
So the new product? Yes. Okay. Thanks.
We had one more.
Okay. Good morning, Lucy Golder, Scotland, France, Europe. It's been a constant frustration of mine that there are different ways of approaching treatment globally. And as it's been now brought up by doctors, experts, researchers, patients, I don't think there's any regulators in the House, but it seems that it is a universal or a global problem, and it's something beyond my comprehension why in Canada a doctor is forced to watch his patients decline. In the States there is amazing results for babies. Why isn't there an organization that can control, help, lobby, put pressure on? I don't know, I'm not an expert, but it's beyond my comprehension. There's one disease, there's all these people who want to make it better, and everyone's facing border problems, political problems, monetary problems. Has anyone got an answer?
I think you make an excellent point, an important point. I think if this would be the price of a painkiller, then we would not have this conversation, because then the regulatory authorities would not make it so difficult. So it's a combined problem of the borders of the world and different regulatory authorizations that have different rules, but the rules also become more strict because the price is really high. So it's a combined problem. You're quite right. And yes, we should get across borders, but I think there's more than borders to solve.
So on that high note of trying to solve the problem, and also to say we have solved the problem, at least for the infantile cases, I think most countries are in agreement that a higher dose is impactful and much needed. And so I think the more we work as a community, as a team, and with support from the AMDA and each one of you and the patient voice, I think we will continue to make a difference.